Welcome. My name is Michelle Morand, and I'm here with Alexander Rowland, who we affectionately refer to as the cancer guy, because that is his jam, his passion, his area of expertise, especially leading edge technology for diagnostics and treatments. And the purpose of our meeting with you today, or anybody who's watching us a little ways down the road, is to discuss gynecological cancers, what they are, how they form, looking at a few different types, which we'll get into in a moment. And most importantly, Alex is going to take you through some information about the most current options for treatment and how they're benefiting patients with those different types of cancers and why they work so much more effectively than standard care in most cases. Let's see, I guess I should tell you, my background is actually in the mental health and counseling field. And I got into this work through my knowing of Alex, but especially because of the loss of my uncle about 11 years ago to cancer, and my experience of trying to help advocate for him and having Alex's support to find treatments and how hard it was to get oncologists on board with those things. It really made me feel a sense of urgency to ensure that patients and their advocates were as well educated as possible about their type of cancer and about the most current technologies and treatments available, and how to advocate for themselves. So that's my role in the work that I do with Alex. And Alex is the science and gathering the most current information and applying it to each individual client that we support. Alex, is there anything you'd like to say by way of introduction to yourself or what we're about to discuss today?
I think you've summed it up very nicely.
Thank you. All righty. Well, then let's get this show on the road. So I'm going to share my screen. So I'll somewhat disappear, and Alex and I will talk you through the first kind of general bits about gynecological cancers, and then Alex will take over to talk about these innovations in treatment. I don't see any chat, so I'm assuming everybody's needs are met at this point, and we'll just go ahead with that. Let us begin the slideshow. Woo. Okay, so you should see Alex on one side of your screen, and then you should see this lovely slide all about gynecological cancers on the other. Is that how it's looking for you, Alex?
Yeah, the far left is cut off of the slide.
Ooh, no, I wonder if that means, that's probably just how I made the slide actually, but let's hope it's not the case all the way through. Let's go to the next one and see if that's the case. That's better, right?
Yeah, it's still a little to the left.
Oh, isn't that interesting? I wonder why. Oh, well, we're going to go with it as long as it's not cutting off the verbiage.
Yes.
Yeah. Okay, so I'll just run you through this. Let's see here. So just going back one. Help me out here, Michelle. No, we're going too far. There we go. Okay, so here today, we're going to talk about gynecological cancers, what they are, how they form, how they're treated in standard care. Note, standard care is always evolving as well, just not as rapidly or as efficiently or effectively as precision oncology, which we'll get to shortly. But we're going to talk about how gynecological cancers are treated traditionally. And we're going to talk about what's new and why these innovations in treatment are working so much better. And I wanted to let you know, these are the types of tumors we're going to be specifically addressing today. Alex can answer questions about other types if this isn't relevant to you specifically. But when we get to the section on precision oncology and innovations in treatment, we're going to talk about examples for low-grade ovarian serous cancer, high-grade ovarian serous cancer, endometrial cancers, cervical cancers, vaginal cancers, and choriocarcinomas. So Alex, should I just run through this quickly, the kind of standard approach?
By all means, yes.
Yeah, because that's something I can do with confidence. Okay, so as you probably know, typically these things are diagnosed because you go to the doctor with some complaint, or maybe you had some sort of routine test that turned something up. And usually from there, your doctor will recommend some sort of imaging test. They want to kind of see inside and try to get a sense of if there's a mass there and what it might be. So you might have an ultrasound recommended, or a CT, or an MRI. Those are very common in standard care. An ultrasound could be a place to start for gynecological cancers, but if there's some concern, your doctor will almost certainly send you for a CT scan. And if they're contemplating surgery, MRI would be applied. So with CT and MRI, standard diagnostics, imaging diagnostics, what they're really looking to see is there something there where there shouldn't be something? Like in the normal human, there wouldn't be something there, or it would only be this big. And what's it look like in you? What's important to note about CT scan and MRI when it comes to cancers is that individual CT and MRI scans cannot equivocally determine whether something is cancer. In other words, they can't be used to diagnose cancer. They can only show if there's, again, something there that shouldn't be, or it's bigger than it should be in an average human. So one of the big problems we have as a support team of cancer patients is that in standard care, CT scans are used to diagnose and also to monitor treatment. But again, they can't actually determine if the mass is cancer, if the cells are live or dead. So it's somewhat problematic. The other problem with these scans is what they're doing, rather than independently identifying cancer, is they're looking over a series of scans, usually 2 to 3 scans over 3 to 6 months, in order to determine if what they're seeing is growing and to what extent, in order to decide whether it's benign or malignant, and or live or dead. In other words, just scar tissue or something that is growing. So with cancer, you don't want to wait 3 to 6 months to find out if you have it and get started with treatment, because usually by the time you start to have symptoms, you've already got some significant progression, and treatment is really critical. In precision oncology means personalized cancer care. So using the most current and most beneficial resources medical science has to come to you and your case specifically. So in precision oncology, precision imaging, or a better approach to imaging, is the PET-CT. The PET-CT is a type of scan that it can tell you with one scan whether what that mass is in your body is cancer or not. Because of how it works, you're injected with a radioactive isotope, and because cancer cells, it's got glucose attached to it, it's in a bit of a circle.
There's many different isotopes that they use now, but the standard one is called FDG, and it's basically like a sugar.
Okay, so it's very like a sugary syrup, and it's got this little radioactive isotope in it. It's injected into your body. You wait about half an hour, and then you go into this machine. It's not as claustrophobic as an MRI. If you've had one of those, by the way, you don't have to kind of go all the way in. But you're in this machine, and the cancer cells preferentially drink up that substance because of the sugar. They're hungry, they're thirsty, and they want lots of that. So wherever that radioactive isotope is glowing the most is indicative of cancer, with the exception of a few parts of your body, including your brain, which are also very thirsty for sugars and like to drink that up too. But the most important thing here really is that with one scan, within a couple of hours from the start to end of your test, you know whether that mass in your body is or isn't cancer. You don't have to wait 3 to 6 months, repeat scans, etc. You also know where exactly it is, if there is metastasis or something like that. And that's quite critical also with cancer. If there is, oh, Alice, you want to say something?
May I just add something there, Michelle?
Please, yes.
Yeah, one of the fundamental things that the PET CT does do is the amount of this radioactive sugar solution that each tumor drinks up is determined by how aggressive and how fast it's growing and its metabolic activity. So a lump that drinks up more of this sugary radioactive solution is going to glow much brighter. And it's going to have what we call a higher SUV, which is referred to as a serum uptake value. So a very aggressive cancer can be very small. It can be a tiny little lump that's drinking up a lot of this, and it may have an SUV of 28 or 30, whereas a much larger lump that the oncologists are focusing on may only have an SUV of about 3 or 4 and may not be very aggressive and unlikely to metastasize. So one of the fundamental things that it really tells you with the PET CT is how aggressive each lump is if it is indeed a tumor.
Thanks, Alex. That's such a critical piece to add. I was really more focusing on, let's just find out if it is or isn't. But
of course,
once you know that it is, you want that extra data, which are the most aggressive, which need to be targeted with radiation or surgically removed as quickly as possible. Yeah. So once we know for sure that's what's going on, or actually in standard care, because PET CT isn't typically used in Canada, in other countries it is. Biopsy is what would happen. We see something on a CT or an MRI, and your GP still, usually we are not sent to an oncologist until this process is kind of run through and you've had a biopsy of some sort. The biopsy is trying to determine, taking a sample, whether with a needle or scalpel or other approaches, to find out if in fact this is cancerous. And the biopsy itself then gets sent, hang on a second, where did my thingy go? Gets sent to a pathologist. Usually there's a pathology lab associated with the hospital where your procedure would be conducted, and that's where your tissue gets sent. And the pathologist assesses your tissue for certain indicators of malignancy. Really, that's kind of basic pathology. They're staining your tissue sample to see if it turns certain colors to identify malignancy, at which point you would be diagnosed with cancer, and your GP would receive this information and then refer you on to the cancer clinic in your region. So that's kind of standard diagnostics, CT and or MRI with a follow-up biopsy. And then the pathologist determines, yes, it is cancer. And now you're in the queue to see an oncologist. And that process, as you're probably well aware, depending on your doctor and the time and the system and all this stuff, it can easily take a couple of years depending on your symptoms, but commonly at 3 to 6 months, would be a minimum. Would you say, Alex, in our
Yeah, it could be more than that. I've seen patients wait, a year.
Mm-hmm. Yeah, it's a long time. So when you can arrange out of it, yes, you'd have to pay out of your own pocket, but you can get a PET CT scan. It costs about $2,000. It takes about a week to coordinate privately, and you'd know with absolute certainty, yes or no, it is cancer, where it is, which tumors are most aggressive. So that's a critical piece of diagnosing cancer effectively. And we'll come in a little while when we talk about monitoring, we'll come back to talking about PET CT as well. Okay, so standard care for gynecological cancers and standard care for pretty much any type of cancer, it usually includes some type of surgery, unless it has metastasized too far or it's in a location that the surgeon thinks would be too dangerous for surgery, and some type of chemotherapy, of which there are numerous now. We'll talk about pros, cons, and when chemotherapy can be beneficial, and radiation. It used to be there was kind of just a few types of chemotherapy, kind of a shotgun approach, and same with radiation. You just got radiation everywhere. Now there's some advances to these types of treatments. There's types of targeted chemotherapies, which we'll talk about shortly, and targeted radiation. So it's far more precise and the side effects are less, and that's what matters most as a patient, I'm sure. Anything you want to say about that, Alex?
No, I think you summed it up nicely. I did want to reflect briefly. You had some statistics you did on when patients get a PET CT outside of standard care. Maybe you could expand on that, or did you want to save that for a later part of the chat?
Hang on, I can go back there. Where was that? PET CT outside of. Oh yeah. Well, the World Health Organization released a report last year. They did an assessment of cancer care around the world. And one of the statistics that stood out to me specifically about diagnostics was that cancer diagnostics in Canada are towards the bottom of the pile. Out of 28 countries with public health care that were surveyed, we came out 23 out of 28 for how we diagnose cancer, how effectively, how efficiently, and the tools that we use. So that's a significant statistic. Like we have a lot to be proud of in Canada and in our medical system and what it provides in contrast to other countries. But when it comes to something like cancer, this statistic is something to keep in mind. And again, all the more reason for you to start to take matters a little bit more into your own hands and make sure that you're supplementing what the public healthcare system provides with these enhanced diagnostics and treatments that we'll talk about shortly.
Yeah, and if I may add to that, I love the statistic you added there that when a patient does get an external PET CT or a private PET CT, in over 80% of the time, it changes the plan or the treatment plan that the oncologist had. And, you know, from our experience, what we've seen is oncologists treat patients based on CT scans of lumps that weren't necessarily tumors or benign lumps and ignore the actual tumors. We've also seen in a lot of cases where patients are told they're cancer-free, and then when we get them a PET CT, we uncover all sorts of tumors. So, you know, I think the statistics of a CT and an MRI in a lot of cancers is about 50%, 60%. So you're missing a lot. With a PET CT, it's up in the 90s, high 90s typically.
You mean accuracy?
Accuracy, and yes, false positives, false negatives, you know, that sort of rate. But importantly, we've seen cases where patients, you know, we had this one terrible case where an individual was being treated for lung cancer, and he was on his 6th chemo treatment. He was an older individual. He decided he was going to sell his business and his house and, you know, do his bucket list. And he came to us and said, you know, I've been on this chemotherapy, and yeah, the chemotherapy's beating me up, but, you know, I just don't feel like I have cancer. And I said, well, you know, it's common. A lot of people feel pretty good until, you know, the cancer is very advanced. I said, why don't we get you a PET CT? So we got him a PET CT. And shockingly, he had never had cancer in the first place. The doctors were treating a benign lump that they thought was a tumor based on a CT scan. So having that PET CT is everything in cancer. It's really important because you can miss tumors, or you can be incorrectly diagnosed, or the doctors could be focusing, for example, radiation therapy or other therapies on a lump that's not even a tumor, or maybe is not the most aggressive tumor, and ignoring an aggressive tumor. Mm-hmm. So very important to get a PET CT, regardless of the type of cancer you have.
Yeah. You guys you're probably rolling your eyes right now, everybody. It's like, come on, people, get on with it. We get it. Get a PET CT. So that's good. That's exactly what we want. We want to annoy you into caring for yourself in that way. It's so worth it. So worth it. There's a question in the chat that's specific to PET CT, so we'll address it now. The question was from Allison about whether the radioactive isotope, and specifically the sugar, might actually expedite the growth of a tumor, because we know sugar kind of helps cancer grow. Cancers like sugar, and oftentimes diets specific to cancer care recommend greatly reducing or eliminating sugar altogether. So what effect might the amount of glucose solution with that radioactive isotope influence the growth of a tumor?
Well, I think that's a great question. And I think a lot of people have some confusion on, you know, radiation and cancer and sugar and cancer. So radiation causes mutations in genes that protect you from protect your cells from becoming cancerous. So typically what it does is it causes damage to a class of genes called tumor suppressor genes. And these are genes that are involved in maintaining the integrity of your genome and preventing your cancers from, or your normal cells from developing into cancers. Because cancer is a disease of DNA, of genetic mutations, a high accumulation. So a lot of radiation exposure can cause cancers, 30, 40 years down the road. But it's definitely a long delayed time period because, of course, that's dose dependent. It's a fairly small dose in the PET CT. It's something like a sunburn, a bad sunburn. And then additionally, the sugars are not going to have a lot of impact because that's another long-term feature of cancer. Cancers like sugars, they preferentially drink them, but they can use many different sources or many different molecules for energy. So in actual reality, in certain types of cancers, scientists were noticing that after patients got a PET CT, the cancers are actually responding in a, we're shrinking, almost like a treatment. So the whole world of PET CT has developed into something called theranostics. And theranostics is targeted radiation of tumors. So in other words, the isotopes that were used to bind onto these tumors, it was a sugar in this particular case with PET CT, with FDG PET CT, has led to a whole new type of treatment where patients get injected with a radioactive isotope that binds onto their tumors. So I would say PET CT in most cases, if it's going to affect your tumors, it's going to slow them down from growing. So it's going to have a positive effect on reducing your cancer.
Well, that's great.
Yeah.
Another question about PET CT from Lucy, which I can address. Given that it is not standard, how do we get one? There are a handful of private PET CT clinics across the country, none on the prairies. In case that's where you are, you'd have to come to BC or head over to Ontario. But there are a bunch. Again, a little administration, a couple of forms to fill out, and usually within a week you have your scan, and within 24 to 48 hours you have your results, which your oncologist will use and apply to your treatment. So there's incredible value in doing that, that's for sure.
Yeah, about 50% of the oncologists that we work with are adamant about PET CT. Another 30% will go with the PET CT once they're explained exactly the context and the importance of it in this particular patient's situation. But however, the vast majority of oncologists in the Canadian system who do swear by PET CTs tell me that in most cases, probably 4 out of 10 cases, they get turned down when they ask or when they submit a PET CT through their local hospital or local treatment facility. So it's not that oncologists don't want this, it's just that the resources are not there to do every Canadian patient. I mean, in BC, we had one PET CT for many, many years, 30, 35,000, 40,000 new cancer diagnoses every year. That machine could do maybe 1,000 or 2,000 PET CTs a year. So we're not even close to that.
Right.
Washington State has, I think, 400 or 500 machines. So, it's just
not quite
Canada,
that many, but they
Canada has not spent the money on that yet. And that's
they're don't quite have 400 or 500, Alex, but the statistic is there are literally almost 4,000 PET CT machines in the US versus 40 in Canada. So just for comparison because they're used as part of standard cancer diagnostics in the US and in the UK and other places, Australia, etc. Okay, let us move on to other stuff here, and then we'll come back to these other questions that are showing up. Okay, so we talked about biopsy, we talked about pathology, we talked about standard care, essentially surgery, chemo, radiation. We're going to talk again a little bit about targeted chemotherapy as we get into the discussion on targeted therapies. Okay, and now we're going to talk about precision oncology. As I said earlier, that is simply defined, that is personalized cancer care. It is using the most current diagnostics and treatments directly applied to each individual cancer patient as they need it and when they need it. Our system is miles away from using precision oncology to its fullest extent right now, but we're here to tell you a little bit about what it is and what it looks like and how, again, to help the public healthcare system provide you with better care. Our whole job here at Cancer Treatment Options and Management is helping cancer patients not have to travel, not have to change doctors, and still get a far more accurate diagnosis and a far more effective treatment. And we've been at it for over 11 years in Canada with some great success across the country in all provinces. So we'll help you figure that out. Okay, so if you think about precision oncology as having 4 main elements, just to try to simplify it for you to remember, again, you'll get copies of this presentation, but in your brain, I want you to be thinking, okay, there's the diagnostic piece. I want to make sure that I get proper genetic and molecular testing, and we'll tell you what that means in a moment. Then I want to make sure that somebody who knows what they're doing and has the time is actually taking a look at what that data that I've just gathered from these tests means for me based on my history, the mutations that showed up in my case. And then we want to make sure that somebody's actually designing a treatment plan based on that data, not just saying, oh, you have ovarian cancer. We usually give everybody with ovarian cancer this. That is not precision oncology by any means. And you want to make sure somebody's really taking a look at what's happening for you and designing a treatment plan specific to that. And then the last pillar of precision oncology is special types of treatment monitoring. So we've just kind of gone on about PET-CT. That would be one of those elements ideally, but we'll talk about another one that's really critical to make sure that you find out as quickly and as accurately as possible if your treatment is working, when you're cancer-free, and when there's a recurrence. So we will just talk a little bit about genetic testing. So Alex, would you like to take over now and talk a little bit about this stuff?
Sure. Yeah. And thank you, Michelle. You've done an amazing job. I really love the way you are able to simplify these complicated scientific concepts.
Thank you.
So genetic testing. Well, as we know, cancer is a disease of the genes and the DNA. I'm hoping everybody knows what that is. It's the coding that makes up all biological life. And so it's separated into chromosomes, and those chromosomes are subdivided into genes. Each gene has a specific function. It creates a protein or some sort of enzyme, creates a biomolecule, and these biomolecules fit together and work together and create biological life. So what happens in cancer is you will have damage to 4 specific signaling pathways in cancer. So in other words, a normal cell will accumulate a mutation in one pathway, and then it will accumulate another mutation in another pathway, and then another mutation in another pathway. And once you have these mutations in these 4 individual pathways, then that cell will become cancerous. So there's specific pathways, they're well defined, we know what they are. But there's many, many different genes in each pathway. So every person's cancer is very unique. Could you go back, please, Michelle?
Sorry, I didn't mean to do that. There we go.
Yes. So in other words, these 4 different pathways that are mutated, and many different genes occur in each pathway. So one person may have one gene in the pathway mutated, where another person may have a different gene in the pathway mutated. And of course, each gene can have a variety of different mutations. Each mutation is going to radically change how that gene functions, or it's not going to do anything to the gene. There's going to be a whole set of different things that can happen here. So the thing to understand is that mutations in DNA cause cancer. There are specific genes. There's 2 classes of genes that we look at. They're called oncogenes and tumor suppressors. Tumor suppressors are genes that protect you. They're turned on 24/7, and they protect any sort of, they repair mutations in your DNA. So if you get exposure to radiation or sun or some sort of carcinogen or chemical, and it causes a mutation in your DNA, then your tumor suppressor genes will fix that. However, if you have damage to your tumor suppressor genes, if they're mutated, then they can't fix it. And these mutations build up and accumulate in certain cells, and those cells become cancerous. So targeted therapies and most treatments, or most of the technology of cancer in the last 20 years has been on targeted therapies of some sort. So what a targeted therapy is it's a drug that will target a specific mutation. So if you have a mutation in your BRAF gene, if your V600, your valine at the 600th position of the gene is mutated, and it's, let's say, turned into a D amino acid, then there's a drug for that will target any cell in the body that has that particular mutation. So assuming that all of the cells that have the mutations are cancerous cells and your normal cells don't have the mutations, then these drugs will only target cancerous cells. So this is where technology is right now as far as cancer treatment. We're looking at targeting every single mutation we can.
Yeah, and the thing that's most important for you folks who are listening is what that means is more effective treatment, fewer side effects.
Yes, definitely.
More effective treatment, fewer like curative, or certainly making it something that is more of a low-grade chronic illness as opposed to a death sentence, which it used to be.
Yes. So in short, we focus a lot of attention and efforts on what we call tumor DNA testing. And that's where we isolate the DNA from the tumors and find out what mutations are causing your cancer. So there's many companies doing this. I believe, Michelle, you had a statistic of about 7,000 different genetic tests, tumor DNA sequencing tests. So this is different than the inherited genetic testing, which looks at damaged tumor suppressor genes that are in all of your genes. Those tests don't determine, they determine a susceptibility to cancer. They don't determine a mechanism that causes cancer, just an increased sensitivity to certain carcinogens. Whereas tumor DNA sequencing actually determines what is causing your cancer and how to target it. Mm-hmm. Okay, next slide. Okay,
yeah, so you've just run through about the next 10 slides here. Okay. So we may go quickly
going over it.
Yeah.
Yes. So
okay. Yeah. So the statistics, 7,000 different genetic tests out there. I mean, we've just basically talked about why it's so important to get genetic testing, because you can't get these targeted therapies without it. But there are 7,000 different types of tests out there, and not all of them are specific to cancer, but there's a lot. So if you've already kind of tried to figure out what are the best tests, you're probably feeling quite overwhelmed. So what we're about to do is kind of walk you through some of the key things that you need to be keeping in mind and what you want to be looking for if you're going to get this type of testing, which everybody should. Mm-hmm. Absolutely. So do we want to just briefly run through these concepts of fusion genes, mutations, and overexpression, Alex?
Yes, definitely.
Okay.
They're very important.
Let's go through here. So tell us briefly about a fusion gene.
Yeah, so there's 3 different mechanisms, as you mentioned. There's fusion genes, mutations, and overexpression. So all of these processes have one result. Well, one basic result is they cause genes that are supposed to be turned off, they cause them to be turned on. And they can also cause genes that are supposed to be turned on, off. So genes that are supposed to be turned on but are turned off are tumor suppressor genes that protect you from cancers. And genes that are supposed to be turned off but accidentally get turned on are what we call oncogenes. So a fusion gene is a type of oncogene. And what happens here is the component of a gene, in other words, the control region that turns a gene on and off. Think of it like a light switch. It's like the light switch of the gene. So when you flick the switch, the gene gets turned on, and when you flick it off, the gene gets turned off. In a fusion gene, what happens is the switch to a gene that is supposed to be on all the time gets attached to, gets crossed over and attached to the gene that is supposed to be turned off. So often the genes that are, oncogenes are typically genes that are involved in growth and development in your embryonic state. So when you're in your embryonic state and you need to have your fingers grow a certain length, then certain genes get turned on, and they get turned on to the point where your fingers will grow to a certain length, or certain bones will grow, or certain organs will grow. And then after that, once you become an adult, those genes are turned off and they're never turned on again unless you need to replace certain tissues. So they'll be turned on briefly to replace certain tissues. This is also equivalent to what we call the wound healing process. So in fusion genes, what happens is these genes that are going to grow, are going to create more cells to grow a finger or replace a tissue that's been damaged, such as scar tissue or something. These genes that are only supposed to be turned on briefly get attached to the control region for a gene that's turned on all the time. And then this gene ends up being turned on all the time when it's not supposed to. And so the consequence of that is it causes cells to constantly grow and reproduce. And basically that's what cancer is, a cell that is constantly reproducing, and these cells go throughout the body and create metastasis and plug up organs. And that's basically what cancer is. So next slide. So a mutation has the same sort of function in regards to cancer. Typically, a mutation will occur in part of the gene that, that binds to another gene. So genes, when they function, will interact with other genes. And typically, when we have an oncogenic mutation, what happens is this gene is supposed to be turned on briefly for a short period of time to repair some damaged tissue. But what happens is this mutation causes it to stick to its partner gene and stay stuck there. And it results in something called constitutive signaling. So in other words, it's only supposed to be turned on briefly to repair some tissue, but it gets stuck to its partner and it can't release. So it results in a constant signaling process. And that signaling process is typically to grow and divide and produce more cells. Next. And then there's overexpression. And overexpression is what we call an epigenetic process in most cases. So all of our cells in our body have the same genes. The reason we have different tissues in our body is some genes are turned on in some tissues and other genes are turned off in other tissues that are turned on. So we have differential gene expression. In other words, expression basically means a gene is turned on or off. Overexpression means it's turned on for too long and it's constantly turned on. Underexpression means it's not turned on for as long as it's supposed to be. So overexpression is something that happens typically in cancers. It's an epigenetic process, as I mentioned. And so our our cells create different tissues using the same genes by turning on some genes and then turning off other genes. So theoretically, we have the genes to grow wings if we wanted to. And if we could turn those on, we could grow wings, in theory, of course, but they're never turned on in humans. And so that's because epigenetic control prevents those genes from being turned on. And so what happens in cancers is there's changes in the genes that control this epigenetic regulation. They get mutated as well. And then all of a sudden, genes that are supposed to be turned off get turned on, and they get turned on too long. And that is a cancerous process as well. So you can go to the next slide. So the three types of tests we use to determine what these mechanisms are is really important. Because you can't target, you need to know what these mechanisms are in your cancer before you can decide which drugs will affect them. So we have drugs that will target fusion genes, we have drugs that will target overexpression, and we have drugs that will target specific mutations. You need to know what is causing your cancer and what the mechanism is before you can come up with the proper precision oncology treatment for you. So the three types of tests we use for this are tumor DNA sequencing, and this detects mutations that turn genes on constitutively and also fusion genes in some cases. And then RNA expression test, which tells us if the gene is turned on too long through epigenetic regulation or what other, any other mechanism. And then there's also inherited mutation testing, which tells us whether you have damaged tumor suppressor genes and other potential oncogenic tumor mutations. So you have an increased sensitivity to certain carcinogens. Next slide. So tumor DNA testing, as we described that previously, basically what happens is we take a sample of your biopsy, or we can isolate tumor DNA from the blood in a new process called liquid biopsy. What we do is we isolate these tumor cells, and then we extract the DNA from them. And then we look at about 500 or 600 different genes that are involved in cancer that we have targeted therapies for. And we find out what mutations are causing your cancer. And then we can come up with a combination of drugs that target those specific mutations. So chemotherapy works a little differently. Standard chemotherapy, what it does is when it gets injected into you, or when you take it in a pill form, what it does is it kills any cell that happens to be rapidly reproducing. So most chemotherapy drugs interfere with the cell cycle. The cell cycle is just a reproduction. It's like having babies. It's when a cell becomes pregnant and with its daughter cell. They don't become pregnant. What happens is they split in half and divide and share their genetic information. So most chemotherapy drugs will interfere with that. However, the problem with standard chemotherapy is it's only effective when it's in your body, and it's only active in your body for typically a few hours. Some chemotherapy drugs will last, 10, 12, 24 hours, but they only affect the cells that are rapidly reproducing at that time. So if you have a tumor that just doesn't happen to be growing at that particular time, then chemotherapy is not going to affect it. And it's also not going to affect the stem cells that cause cancers too. So knowing what DNA mutations you have is really important, because then we can use targeted therapies and not have to rely only on chemotherapy. Next slide. So then there's RNA expression testing. So this is a great new technology that we've just started using. We've been using it in cancer research and drug development for a long time. But now it's actually come down in price, and we can actually look at 20,000 genes in your tumor sample. So what we do is we'll take, for example, if you have ovarian cancer, we'll take a sample of your tumor and we'll look at the actual amount that 20,000 genes are being expressed. And then we'll take a sample of your normal ovarian tissue and we'll compare that to the tumor tissue and say, oh, you have 17 genes that are overexpressed. Then we'll match those to certain drugs that will target those 17 genes that are specific to your tumor cells. So this is a wonderful new technology. It's really good for tumors that we don't have a lot of information on, or rare tumors, because it almost always comes up with a profile of different drugs that we could use. Additionally, there's been a lot of new technologies, artificial intelligence. We use one test that actually has this database of drugs, and it will match this database of drugs to your 20,000 different dysregulated genes. And it uses this massive artificial intelligence computer to come up with a match. And so you may get matched against a drug that's used in heart medications, or a drug that's used in dental surgery, or who knows. We've seen all kinds of crazy matches. One of the things we've seen is a disease called angiosarcoma. And we found that in certain cases, a heart medication is really good for that when a certain gene is overexpressed. So both of these tests are really important for determining what sort of advanced precision oncology treatment options are available for you. So next slide. So inherited testing, most of you know of BRCA1 and 2. These are tumor suppressor genes, and when they're damaged, they can't repair mutations. It's a little more complicated than that, and there's probably about 15 or 20 different genes involved with the BRCA1 and 2 genes that you also need to do. But basically, when we see a cancer in a person that is under 50 years of age, we assume that they've had some inherited mutation. This is important because it can tell you whether you have an increased sensitivity towards certain carcinogens. So there's many different cases of this. It does not mean you're going to get cancer if you have an inherited sensitivity mutation. It just means you have to alter your behavior. So for example, if you have a BRCA1 or 2 mutation or an ATM mutation, then you can avoid smoking and drinking heavily and monitor yourself, get MRIs every couple of years or something, and just stay active in watching for a potential tumor. So you can catch it when it's really small and when it's easily treated, when you could just cut it out when it's a small little tumor or a small group of cells. So with any cancer, the earlier you catch it, the greater your chances are of success. Once the cancer gets into your body and starts metastasizing, then it's really difficult to treat. But if you can catch it when it's an early stage, then usually it's curable. So knowing that you have a sensitivity towards certain carcinogens because you have an inherited mutation can basically allow you to be conscious of catching a tumor before it really causes you any damage. So inherited genetic testing should be done for everyone, in my opinion. Okay, next slide. So gynecological cancers, precision oncology. So great statistic there, Michelle. I love that, 100,000 clinical trials in the world. That goes up and down quite a bit, but typically it's at least 100,000 different clinical trials in the world. Most of these clinical trials are for specific molecular features. So in other words, you're not going to get into this clinical trial unless you know that you have a certain molecular feature through either expression testing or tumor DNA sequencing. So a lot of the time, if you know what your mutations are, then you can go through the clinical trial database called clinicaltrials.gov, and you can say, well, I have a BRAF mutation, or I have an mTOR mutation or a PIK3CA mutation. There's 15 trials for people that have my mutation, all these different drugs made by different drug companies. This one looks like it's going to be the best. Let's try that. So, it's really important to understand the molecular basis of your cancer. And unfortunately, that's not being done enough right now. The tools are here, but I think the expression that I heard once was very well said. The future is now, it's just not well distributed.
It's a good point, yes.
Yes. Next slide, please.
Okay. I added this little bit of info in because I thought people, we talked about biopsy earlier and PET CT and kind of the difference, standard care. So here's I think an important thing for people to understand. If, you've just spent all this time talking about how critical testing tumor tissue is, whether for overexpression or tumor DNA and certain mutations. So tell us a little bit about this.
Yeah, so because of this technology is, and there's so many great new technologies being applied to cancer right now, it's hard for the medical system to catch up. Yes. It really is, all at once. Certain hospitals will adopt a new technology that others don't have. One of the biggest problems right now in Canada specifically is when they do take a biopsy, they don't always do it through a PET CT. So a PET CT will allow you to determine what is the most aggressive tumor, and that is obviously the best one to biopsy. In many cases, doctors will just choose a tumor based on its size, and it may not have a lot of tumor cells in it. It may only have 20% tumor cells in it. And that's not going to provide a lot of DNA or RNA for accurate genetic testing. So we find that in Canada, probably 40% of the biopsies we get fail. And that's unfortunate, but we have a solution for that. What we do is we have this great new technology now called a laser technology. It's a laser beam. It's very expensive, unfortunately, but it is a wonderful new technology. So we have a lab in the States that we send our Canadian biopsy samples to, and they use this laser beam that can scrape these tiny tumor cells off without damaging them and help release the DNA and the RNA. And we also have invested in a lab that does tumor DNA sequencing with a robotic system that is specific to poor quality biopsy samples. So when we use one of the popular or FDA approved technologies, we get a lot of failures. In other words, they'll take the sample and 40% of the time, sometimes 50% of the time, they'll say, oh, here's your results. Sorry, it's not so good. We didn't get a lot of DNA and RNA. It was poorly degraded. So we're working on that. And two of the technologies we're using right now is this laser extraction process. And then also our new sequencing technology that is optimized for poor quality biopsy samples.
I just want to add two things there, or just clarify a few things. That 40% of the time, 40+% of the time is not our statistic. You just said we find, but that was the big we. There are numerous clinical studies that have presented this statistic. And you also mentioned something about very expensive, and in reality, if we think about quality of life and making sure you get the right treatment and that you don't waste your biopsy sample on a test that has a likelihood of failing, like Alex was just talking about. But if we talk about standard testing, the preparation of your sample usually costs a few $100s, but this is the standard testing that fails more than 40% of the time. Using the laser separation costs about $1,200 as opposed to a few hundred, which, for some people I appreciate might be a lot. And when you're thinking about making sure that you actually get this testing, get the right treatment, is not an exorbitant sum. So that I wouldn't call it very expensive for most people. Just wanted to point that out.
Thank you. Yes. And I was referring to we as a scientific community.
Okay. Yeah. Yeah. So about the biopsy handling, like how your biopsy is treated once the surgeon has removed it from your body, whether through needle or scalpel or however your process was, how the surgeon handles it, not just what Alex said about where they get it from in your body and making sure that's a good tumor to produce lots of that tumor cells, but how the surgeon handles it, how the pathology lab treats it, even things like what's the weather like. If it's really hot, certain types of tissue like RNA will degrade much more rapidly. So there are techniques and protocols in place now in some countries around the world to address this issue, to make sure that surgeons are well educated, that tumor tissue is well handled. But it isn't being done here just yet.
Yeah, I like the old adage they used to say. I remember, never buy a car that was made on a Friday, and never get a biopsy done on a Friday.
Because your sample will sit for days before anything happens to it. Yeah, it's a good. We could go on about those things, but yes. So there are ways, again, to make sure that you get a biopsy from the right and best place, that it's well handled. Now, for many of you watching this ship may have already sailed. You may have already had your biopsy, and that's why we went over the concept of the laser separation, because we want you to know there's always hope. There's always a way. There's always a workaround. You just have to know about it. And know what to do to get it. So now you know, if you're not sure how your biopsy sample was handled, or they said there wasn't a lot of tissue there, you absolutely want to make sure you have the laser separation process done, and not just send your tissue off to one of these facilities, because they will use the tissue that is there and you won't get a full result. So okay, so we talked about pillar 1 being genetic testing, the tumor DNA, the overexpression, the inherited mutations. Pillar 2 of precision oncology simply is just making sure someone puts all that information together, including your medical history, what's going on in your body now, what your past is, what your family history is. the mutations that have been found, how they're going to influence each other in your cancer development, and also as you apply certain treatments, and then putting all that information together into a brief report that is understandable by yourself, but most importantly, it has the evidence and the information that your oncologist needs in order to be confident in modifying their treatment plan for you and applying this to your case specifically. And so those are the components that we consider to be part of that personalized research. Is there anything else you want to add to that, Alex?
No, I think you've done a great job there.
Okay. Now we're on to treatments, and what's new. So maybe it would be helpful, Alex, if you defined targeted therapies again for us. And there's a slide right after this about immunotherapies.
Right.
And then we'll get into specific treatments for attendees. So targeted therapies are?
So once again, targeted therapies target the unique molecular features of your cancer. So the three different molecular features that we look at are: number one, mutations, as defined by tumor DNA testing; fusion genes, as defined by tumor DNA testing and RNA sequencing; and then overexpression, an epigenetic mechanism, as defined by RNA-seq expression testing.
Okay. And these targeted therapies, and back to those 100,000 clinical trials for cancer that are happening around the world right now. And just so you know, you don't have to actually travel to Italy to take part in a clinical trial that is fundamentally based in Italy these days. Most of the time, these trials are accessible to people all around the world. It's really a matter of knowing about them. And there are a number of really excellent clinical trial services, which I can tell you about in a little while. But independent of clinical trials, we have hundreds of different types of targeted therapies already approved for use and available if you just have the testing to prove that you need them.
I wouldn't mind traveling to Italy.
Okay, well, I'm sure you can come up with a good excuse for you to go. And just something about off-label, because Alex will probably be talking a little bit about that. He mentioned an example earlier about angiosarcomas and how, interestingly, through this molecular testing we've been talking about, it was discovered that a really excellent treatment for some folks with that type of cancer is a treatment that was actually designed for heart disease. And without that bioinformatics or that AI program kind of linking mutations and all different types of treatments, we wouldn't know. But that's really powerful information for people who have that type of cancer and that mutation. A very inexpensive, easily accessible drug with minimal side effects is producing massive results for people. Mm-hmm. So off-label drugs are simply treatments that were designed for other things, whether different types of cancer or different things entirely, that have been found to have a proven benefit for your mutation or your type of cancer. And immunotherapy, tell us a little bit about that, Alex.
Yeah, so cancer cells and immune cells have a lot in common. They use a lot of the same molecular pathways. They use a lot of the same resources, a lot of the same growth factors, and they like to feed the same way. Immune cells love sugars, as do cancer cells. Restricting sugars is not necessarily a good thing because you're going to affect your immune cells as well as your cancer cells. So what cancer cells do is they've evolved to hijack the immune system and steal the resources that the immune cells use. So what they do is they have we believe there's about 14 different pathways, signaling pathways, that cancer cells can inactivate the immune system. So what happens when a cancer starts growing? The immune system, the T cells that kill the tumors will go into the tumor, and they will go to investigate it and to break it down. And then the tumors will use one of their tricks, one of these 14 little pathways. They'll disable this pathway, and the tumor cells will then become inactivated. And then the tumor, or sorry, not the tumor cells, but the immune cells will become inactivated, and then the tumor cells will steal their resources. So immune therapy is a class of drugs that are designed to reactivate those pathways that have been inactivated by the tumor cells. So right now we have drugs for, we actually have a new one that's just coming out right now. So we have drugs for about 4 different pathways. Those pathways are called the PD-1 pathway, programmed death 1, and that's the most common pathway for immune therapy. So typically when you hear about immune therapy, it's almost always about a PD-1 drug. There's many companies making PD-1 inhibitors. There's also the CTLA-4 pathway, and there's a class of drugs called CTLA-4 inhibitors. We have about 2 or 3 drugs that target the CTLA-4 pathway. There's another pathway called EDO, and then there's a recent pathway that we're starting to use now called the LAG-3 pathway. So we're working on developing drugs to restart the immune system against tumors. And so these drugs are working very much like vaccines. So we've seen some incredible results from immune therapy. We're actually the first company to ever use CTLA-4 inhibitors and PD-1 inhibitors in patients in Canada. And some of those patients are still alive today. They were on death's door. They had literally months to live. And a few of these treatments just totally eradicated their cancers. So when we see responses from immune therapy, they're typically what we call durable long-term responses, which is a science and a medical way of saying a cure. So durable long-term, we don't like to say cure, but we do like to use the term durable long-term. So there are certain features about immune therapy that we can look at through genetic testing. We call it the lottery. If you have something called high tumor mutation burden, in other words, if you have more than 10 to 12 mutations per million base pairs of DNA, then you have something called high tumor mutation burden. And that means you have so many mutations that your tumors look very different, and therefore inactive or reactivating certain types of pathways that have been inhibited, like the PD-1 or the CTLA-4, can get a significant response against your tumors. There's also other pathways called MSI, which refers to microsatellite instability, and mismatch repair protein damage, which is a pathway that repairs mismatched DNA base pairs. So we'll be talking more about those specific pathways when it comes to treatments. So I just wanted to mention something about immune therapy and what an amazing new tool it's been. So next slide.
Okay, so just revisiting that list that I talked about earlier, just to kind of bring us into the moment here. These are, Alex is going to now present some examples for each of these types of cancer and some of the treatments that are available for them.
Yeah.
Okay, so
we're going to start with ovarian serous because it's the most common one, and this is what most women have. So there's low grade and high grade. I often get asked this question, what's the difference between low grade and high grade ovarian serous? On a molecular level, they're very different diseases. On a pathological level, basically what it means is that low grade are what we call well differentiated. So they look like normal cells. There's not a lot of genetic changes to show that they're very different from a normal cell, but there are those 4 specific pathways changed. Obviously, you have to have 4 specific pathways altered for a normal cell to become a cancerous cell. In low grades, they tend to grow slower. They spread, they're less likely to spread. High grade means that there's a lot of changes in the DNA, a lot of mutations, a lot of damage done, and they're poorly differentiated. Differentiation means how much that cell has become the cell it's supposed to be. So in basic biology, we have these things called adult stem cells, and they produce these cells that basically can turn into many different types of tissues. And so a well-differentiated cell is a cell that has gone through that process and has turned into its final type of tissue. An undifferentiated or poorly differentiated cell is one that hasn't really been changed much from a stem cell, and it still doesn't really have a lot of defining features. So therefore, it's more likely to be able to spread and live anywhere in the body, Whereas if you have a well-differentiated cell, it's going to only live amongst other cells of its type. Because if it does move around, it's going to get destroyed by the immune system. Whereas the poorly differentiated ones, they're kind of, they don't have any specific cell type assigned to them. So they can fit pretty well anywhere, and the immune system won't really recognize them. So they're worse to have, obviously. They're more likely to spread.
They're sneakier.
Yes, they're sneakier.
Yes, yes.
Next slide.
Hang on a second.
So we're just going to go over some of the basic risk factors. I'm sure these are all well established for ovarian serous cancers. Being overweight is one of the biggest factors. Breastfeeding, very important. It's protective. And so I just created had put some statistics here. So what an odds ratio is, it's called the OR, odds ratio. It's the odds of getting a certain disease given a certain behavior. So if you have an odds ratio of 1, then that means that behavior does not affect your chance of getting that disease. If it is above 1, so that 1.5 or 1.3, that means that that behavior causes or has a higher association of you getting that cancer. If it's below 1, then it reduces your risk of getting that cancer. So in this particular case, if you have an odds ratio of 0.75, then what you would do is you would take 1 and you'd minus 0.75, and that gives you 25. And what that basically means is a 25% reduction in risk. So an odds ratio of 0.75 is the same as having a reduced risk of 25%. So if you breastfeed, then you have a reduction of high-grade serous by 25%. Endometrial would be 27%. Clear cell tumors would be 22% reduction, and mucinous tumors, which are very hard to treat, would be significantly more, 32%. So breastfeeding is kind of important for women, especially for reducing gynecological cancers. So standard treatment for low grade, I'm sure most people who've been through this understand what the treatment is. It's mostly surgery and debulking, removing the tumors. And then after that, often women will get put on an aromatase inhibitor. And that's because often these cancers overexpress estrogen receptors, ESR1, as we call it, estrogen receptor alpha. Aromatase inhibitor is something that reduces your ability to produce estrogen, and therefore estrogen signaling is somewhat associated with this cancer. Not true in all cases, but this is pretty well the standard treatment. Next slide. So typically chemotherapy doesn't work well with low grade. So it's not often used. It can be used, but it doesn't really have a great response. Sorry for not mentioning that on the previous slide. So now we're going to get into what's precision oncology. So precision oncology, once again, is targeting specific pathways. So this is a great new study, fairly recent. They used a drug that is called trametinib, and trametinib inhibits overexpression of a class of tumors called MEK. They're part of the RAF signaling pathway. So MEK inhibitors are a type of drug that inhibits that pathway when it's overexpressed. And this pathway is often overexpressed in ovarian cancers. So this recent study was done. They found an ORR, overall response rate. That means how many patients out of 100 respond when given the drug. So in this particular case, 26.2 patients, 26.2% of patients had a response to this drug. And there was a range. And so that range went from 19% up to 34%. So as high as 34%, the average was 26%. So when you see a statistic like this with what we call the 95% confidence interval, it's going to have a range of the low and the high rates, and then the average is what we look at. So 26.2 was the average, the low was 19, and the high was 34%. And this was compared to 6.2% of women that did not get this drug. So significant benefit. And basically it resulted in a 52% reduction in the risk of disease progression or death, which is fairly good. So once again, trametinib, a MEK inhibitor. And then in this particular case, they compared it to the physician's choice, which could have been any sort of chemo drug or anything. And the progression-free survival, which is a median, in other words, it's an average. And what progression-free survival is it's one of the statistics that we use in oncology. It is the duration of time that it takes for half the people in a clinical trial to have their disease come back. Overall survival is the same sort of statistic, but it refers to death instead of disease recurrence. So in this particular case, the progression-free survival, or the period of time where 50% of the disease, 50% of the patients had a disease recurrence, was 13 months, which is pretty good. Some of those patients didn't have a disease recurrence for up to 15 months. So when they compared that to the physician's choice, that was 17.2 months. So almost a doubling of disease-free time for 50% of the patients taking this drug. So definitely a good choice. Now, I do want to mention this was an unstratified trial. So in other words, they didn't actually look and see if the patients had mutations in this MEK pathway. They just gave the patients the drug. So if you do tumor DNA sequencing and you find out you have mutations in your MEK pathway or overexpression of this pathway, then you're going to probably have a much better response to this drug and a longer duration of disease-free survival. Mm. So next slide.
Sure. I just feel the need to just correct a little bit of a slip up there. You said 17.2 months for the physician's choice, but your slide says 7.2, which I assume.
Sorry, did I say 17? Yeah. I thought I said 7.
You did, and it's recorded, so we have proof. But the point is, it was twice as good. The new the MEK inhibitor.
Okay. Yes, it was twice as good. Yes. Okay. So there's also a RAF and a MEK inhibitor. So this is a new drug called VS6766. And it was combined with something called an FAK inhibitor called defactinib. And this is for recurrent patients with low-grade serous cancer. And so these patients had well, in this particular study, they did look at a mutation. They looked at a mutation called a KRAS G12V. And basically what this is it's a gene that is overactivated. It normally has a G amino acid, which is a glycine, at its 12th position. And then in the tumor, it has a V, which is a valine amino acid. So it's supposed to have this G amino acid, and it's been replaced at the 12th position by the V amino acid. And that causes this KRAS gene to stay stuck to its partner and constantly signal. And so in patients that had this mutation, they had a 60% overall response rate. In other words, 60% of the patients responded to this with recurrent low-grade serous carcinoma.
Wow.
So yeah, great responses. So definitely tumor DNA sequencing is important here.
Mm-hmm.
And then so BRAF is another type of mutation. It can occur in low-grade ovarian. It occurs in many different cancers, including melanomas, and we see it in colorectal, lung. So there's this new drug called lifirafenib, and it is an inhibitor of two different pathways, the RAF pathway, the BRAF pathway, and also the EGFR pathway. So in this particular case, the overall response rate wasn't as good. It was 17%, but over 50%, almost 51% of the patients had stable disease. And what stable disease is where your tumors don't grow, but they don't shrink. So, that's kind of, it's definitely a response. It's not a desired response where a complete response where all of the tumors shrink, or even a partial response where some shrink and some don't. But having no growth in tumors is a good thing. So this was specifically in people who had BRAF V600 mutated cancers. And this is a basket study that included melanomas and papillary thyroid cancers, as well as low-grade ovarian cancers. So they looked at a bunch of different types of cancers. We don't actually have the statistics for ovarian alone, but that would definitely be something I would look into, targeting the BRAF pathway if you have a BRAF mutation.
Mm-hmm.
So now we're going to talk about high grade. So typically the treatment for high grade is debulking and surgery. And then typically patients get a platinum based drug. Carboplatin is a common one, and then paclitaxel, which is a taxane drug. Both of these are chemotherapy. Carboplatin is a drug that's derived from platinum, and platinum is something, it's a metal that's used in catalytic converters because it absorbs a lot of hydrogen. And then taxane is something that's it's a plant phytochemical. It's typically it was derived from the Pacific yew tree, although now they synthesize it in the lab. So both chemotherapy drugs, and they both interfere with reproduction of cells. So they're only active when they're inside your body. Unfortunately, they kill all normal cells that happen to be reproducing, such as your your skin cells, some immune cells, the skin cells that line your organs, your hair, different cells and so on. So they kill normal cells as well as healthy cells. PARP inhibitors are a class of drugs that work on a pathway that's involved in DNA damage. And typically what happens nowadays, and this is relatively new, is a lot of women with high-grade ovarian serous carcinomas were found to have BRCA mutations. And PARP inhibitors are drugs that can target cancer cells that have BRCA 1 or 2 mutations. And so in these particular cases, they started finding that even women that didn't have BRCA mutations were also responding to these PARP inhibitors when they're given to high-grade ovarian serous. So the standard care now is often women will get a PARP inhibitor after they finish their chemotherapy as a way of, it's called maintenance therapy, after they get their chemotherapy and surgery, regardless of whether they have a BRCA mutation or not. And then after that, if the cancers come back, typically they're given a chemotherapy drug called gemcitabine. So next slide. So precision oncology, the latest data, and these are 2 different studies, although there's a few different studies that show this. Niraparib is a PARP inhibitor. It's commonly used. However, the data shows it works much better when it's combined with another drug called Avastin. Avastin is a drug that inhibits angiogenesis. And what angiogenesis is it's the tumor-initiated recruitment of blood vessels. So normally muscles and growing tissues will recruit blood vessels in a process called neogenesis. And that, I believe, is 8 steps to creating a new blood vessel formation system. Tumors have their own process where they steal blood vessels, and because they need blood vessels so they can grow and metastasize, and so they can support their high metabolic activity. And their process is not quite as efficient as neogenesis. They're missing the last step, I think the 7th or 8th steps, and those are sealing up the blood vessels so they don't leak. So what happens is tumors recruit blood vessels, and these blood vessels are kind of leaky, and that helps the tumors spread throughout the local tissue. So Avastin is a drug that inhibits that process of angiogenesis. It targets certain proteins called VEGF proteins and other proteins involved in that process, vascular endothelial growth factor receptor proteins. So it's a drug that's been used in many different cancers, but when it's combined with the PARP inhibitor niraparib, it significantly increases the progression-free survival. Once again, that is the time that women on this drug remain disease-free. So typically with niraparib alone, it's 5.5 months. It can range from 3.8 to 6.3 months. But when you combine it with Avastin, it's 11.9 months. More importantly, in one of those studies, the Ovario, the 18-month progression-free survival was 62% for all of those women taking this combination, niraparib plus Avastin. And more importantly, it was 76% in a subgroup of patients that had damage in a pathway called the HRD signaling pathway. So they had genetic mutations in what's called the homologous recombinant deficient pathway. Basically what this is it's a pathway that is involved in repairing certain types of DNA damage. And when patients had mutations in that pathway, they had a much better response to this combination. So once again, 18-month progression-free survival was 47% in the homologous recombination proficient group. That means patients that didn't have damage in this pathway. So that's still really good. So even if you don't have damage in this pathway, you're still getting a pretty good response. I believe it was 90% and 75% overall for the 6-month and 12 months, respectively, in the HRP group, so the proficient group. So you don't have to have HRD deficiency to get a response to this. It's just better if you do. And the way you determine if you have HRD deficiency, once again, is tumor DNA sequencing, because it's just mutations in certain genes. So next slide. So as I mentioned, one of the standard cares for high-grade serous is getting a chemotherapy drug called gemcitabine. And this is in late-stage patients who haven't responded to or have stopped responding to all of the previous treatments. Well, a recent study shows that if you have mutations in a gene called RB1 or CDKN2A, or if you have extra copies of other genes such as CCNE1, KRAS, or a c-MYC gene, then you have something called replicative stress high tumor. And so what they found out is that when women with replicative stress high tumors, they typically had a really good response to gemcitabine. However, if women with high-grade ovarian didn't have mutations or alterations in these specific genes, then they didn't get a good response to gemcitabine. So, you know, a lot of times doctors will say, well, we'll give you gemcitabine. It's either going to work or it's not going to work. Well, now we know why it's not going to work and why it's going to work. And we also know what to do to ensure that it works. We test you first. We make sure if you have any of these mutations, then we know you're going to probably get a good response to it. If you don't have these mutations, in other words, if you don't have replicative stress, then we're going to need to add another drug called berzosertib. It's called an ATR inhibitor. It's a relatively new drug. So typically, if you have this RS high, your tumors will respond to gemcitabine alone. If you don't have mutations in these pathways, then you need to add berzosertib or potentially some other ATR inhibitor. So how do you know if you have this? Once again, tumor DNA sequencing. Next slide. So there's a relatively new drug called mirvetuximab soravtansine. Now this drug is what we call targeted chemo. And so targeted chemo is a really great new technology where they will take an antibody that binds onto the surface of a particular cell. And, you know, it's typically going to be a cancer cell, obviously. And then they will attach one little molecule of chemo to that antibody. So then they inject this antibody chemo. So it's much like a PET CT. In fact, this technology was copied from PET CTs. And where they take this this antibody or a small molecule, it doesn't have to be an antibody anymore. They can use small molecules that will bind onto the outside surface of a particular cell that contains a certain protein. Excuse me. And then they attach this either a chemotherapy drug or even a radiation isotope, as in PET CT. This particular drug targets something called the folate receptor alpha, FR alpha. And this is some sort of tissue factor, which is a secreted protein that's involved in coagulation of your blood. So certain tumors have very high levels of this folate receptor alpha. We'll just call it FRA or FR alpha. And so they designed a drug that binds onto FR alpha. and it has this chemotherapy. It's an antibody that binds FR alpha. And so if your tumor has high expression of FR alpha, then this drug is going to be very beneficial for you, regardless of the type of cancer you have. So in this particular study, they found that a lot of women with high-grade ovarian serous cancers have high-grade FR alpha. In fact, we just did a report for a patient literally this week, and we found that she had, I think it was like 60-fold overexpression of FR alpha. So therefore, this drug is going to be a very beneficial drug for this woman. If you do have a tumor, or if you have high-grade ovarian serous that doesn't have high-grade expression of this drug is not going to work for you at all. So once again, understanding the molecular features of your cancer really helps define which drugs to take. You don't want to be taking a drug unless you know you have the molecular feature for it. So how do you determine if you have high expression of FR alpha? It's a simple test, RNA-seq expression testing. So it's one of the tests we discussed in the beginning. So next slide. And so here's the results from this trial. And so in this trial, they combined it with Avastin, also known as bevacizumab. That's the anti-angiogenesis drug we described earlier. And so basically, they're showing the disease, the median disease overall response, and the progression-free survival. Or sorry, the MDOR is the medium. Let's just focus on the PFS. That's the better statistic. I don't like to use duration of responses, it's a little confusing. I like progression-free survival, but MDOR is duration of response. I think progression-free survival is a better statistic for this use. So in this particular study, they looked at women that were platinum sensitive. In other words, they were still responding to the carboplatinum or platinum resistance. And as you can see, obviously, women that had high expression of this FR alpha and were platinum sensitive had a better response. The overall response rate was 69%, and the progression-free survival was 13.3 months. However, even women that were resistant to platinum therapy still got a really good response. 59% of them responded, and 9.7 months for progression-free survival was good. So, great drug if you have high expression of FR, and obviously the higher your expression is, the better the response you're going to get. So next slide. So here's something on immune therapy. So everyone wants to know whether immune therapy is going to be good for your cancer. One of the first questions we get whenever someone calls us says, hey, can you help us determine whether immune therapy is going to work for you? And by all means, that's one of the things we do. We use both expression testing and tumor DNA testing to determine that. So the types of immune therapy we typically look for, once again, are drugs that reactivate the PD-1 pathway, that's called the programmed death 1 pathway, and the CTLA4 pathway. And so in both these pathways, what happens is you get a high amount of what we call tumor infiltrating lymphocytes. So there's two types of T cells that go into the tumors. There's what we call CD4 positive cells that are called T regulatory cells. They're type of T cell, T lymphocyte. And then there's CD8 positive cells. The Tregs are kind of a modulatory cell. They get hijacked by the tumors, and they are the ones that supply the resources to the tumors, the CD4 Tregs. So we're not going to talk about them. It's the TILs that we're concerned about. So the TILs go in there, and they're the ones that actually will kill the tumors, but they get switched off. And they get switched off by the PD-1 pathway and the CTLA4 pathway that are overexpressed by the tumors. So these CD8 positive cells called TILs, tumor infiltrating lymphocytes, are found within the tumor. If they're found inside the tumor, then all you need to do is reactivate them by giving a PD-1 inhibitor or a CTLA4 inhibitor. So they're not found in all tumors, but if they are found in a tumor, that means immune therapy is going to be good for you. So the bottom line is, when someone asks me whether immune therapy is going to be good for them, the first question I'm going to ask, not them, but I'm going to ask the data is, does this patient have a high amount of TILs? If they do, then all we need to do is turn them on by inhibiting the PD-1 pathway, there's CTLA-4 pathway. These TILs will be reactivated and they'll kill the tumors from the inside out. So in gynecological tumors, a lot of them have high amounts of TILs. So for example, high-grade ovarian serous carcinomas have, 83% of them have high percentage of TILs in them. For low-grade serous ovarian carcinomas, 73% have TILs. And so 72% of endometrial, 52% of clear cells, and 51% in mucinous cancers. So you would think then, great. So ovarian, high-grade and low-grade ovarians and endometrials, there's a really good chance of having TILs, and therefore these immune therapy drugs are going to be very good for us. Unfortunately, you also have to look at other factors. So can you go to the next slide? So once again, there's also high-grade, so there's also another factor beyond TILs, and this is what we call high tumor mutation burden. So unfortunately, in ovarian cancers, the problem is the TILs are located in the stroma, and we've just recently discovered this. So we've, when we first discovered that high-grade and low-grade ovarian cancers had a high amount of TILs, it was great. Let's get these women on CTLA-4 inhibitors and PD-1 inhibitors right away. Unfortunately, the treatments didn't work so well. I think the response rates are about 10, maybe 15% at best. So it didn't work very well, and the responses weren't very durable. So what we found out is, yes, they do have a high amount of TILs in ovarian cancer, but unfortunately, the TILs are not located in the tumors. They get stuck in what's called the stroma. And so therefore, when we reactivate them, they're not on the tumor and they don't attack the tumors. So unfortunately, immune therapy does not necessarily work based on TILs. There is another situation called high tumor mutation burden that we discussed earlier, and that's whether you have more than 10 mutations per million base pairs of DNA as determined by tumor DNA sequencing. So even if you do have TILs and you have high-grade ovarian serous carcinoma, it doesn't mean immune therapy is going to work for you. However, if you do have high TMB, then it means that your tumors are going to look very different to the immune system, and so the immune system will be able to attack them if they try to metastasize. So it doesn't mean that immune therapy is not going to work for ovarian cancers. It just means it's only going to work if you have high TMB. And once again, if you want to know if you have high TMB, you need to get tumor DNA sequencing. So next slide. So another interesting study was the use of statins. And so they found that, statins are used for controlling cholesterol in people with heart conditions and, with arterial diseases. So statins reduce the amount of cholesterol. One interesting thing is that cancer cells need a lot of cholesterol for their membranes, and then for their signaling molecules and the vesicles that they use, exosomes and so on. So cancer cells really need a lot of cholesterol, and they love cholesterol. So if you have high cholesterol, you're basically feeding your cancers. So, definitely reduce your cholesterol intake to reduce cancer risk. This study showed, that women that took statins for all subtypes of ovarian cancer had significantly reduced death rates, mortality. And so they found that that was most significant in high-grade serous ovarian cancers. So women with high-grade ovarian serous cancer had that took statins had a 40% reduction in risk of death. So definitely these drugs are significantly slowing down the progression of the cancer by limiting their ability to use cholesterol to build their membranes and build other components that they need. More importantly, it was a certain type of statin. Lipophilic statins were associated with a 43% reduction in ovarian cancer mortality. And so the lipophilic statins are atorvastatin, simvastatin, lovastatin, fluvastatin, serivastatin, and pitavastatin, which I haven't really heard of the other two statins, but I guess they're still available. The most common one that I see is atorvastatin. So even if you don't have super high cholesterol, but you have ovarian cancer, it's worthwhile getting on these drugs. So next slide. So we're going to talk about endometrial cancer and cervical cancers. So the standard care typically for endometrial and cervical cancers is typically the same sort of thing. They're typically going to use standard chemotherapy. The drugs, the go-to drugs, can you go back, please? The go-to drugs are carboplatin and paclitaxel. And they will work for some types, but often women don't respond to these. The important thing on a molecular level is we now know that there's 4 main molecular subtypes of endometrial cancer. So when someone comes to us with endometrial cancer, we'll do a bunch of testing, genetic testing and expression testing, and we'll try to find out which type of subtype they have. So in the MSI-H, which means microsatellite high, they have a lot of mutations in what we call microsatellites. And these are just little pieces of DNA, little repeats in the what we call junk DNA that are unique to every person. Microsatellites are commonly used in paternity testing and forensic testing because the microsatellites you have are unique to you and your family. And so the paternity tests will look at the microsatellites that you have and compare them to your mother and your father. And if you have what's called microsatellite high, that means you have a lot of altered microsatellites, and your tumors will look kind of different to the immune system. And once again, we also discussed a mismatch repair deficiency and homologous recombination deficiency. These are all different, these are mutations in different pathways of tumor suppressor genes that repair damage to DNA. So mismatch repair is another one of these pathways. So 25 to 30% of women with endometrial cancer have damage in the microsatellite pathway or the mismatch repair pathway. Another 25 to 30% of women will have what's called copy number high. We won't get into that. Another 45 to 50% of women will have copy number low. And then you also have what we call Pol E mutations. So the interesting thing is that both Pol E creates a lot of mutations. So typically, if you have damage in your Pol E gene, you're going to have high tumor mutation burden. It's not always the case, but typically that is what we see. So Pol E and MSI high mismatch repair theoretically will do very well with immune therapy. Okay, can you go to the next slide? So yes, this is true. So if you recall, 72% of women with endometrial cancer have high amounts of TILs. And unlike ovarian cancer, these TILs will determine whether you will respond to immune therapy or not. So we've recently found out that immune therapy is an incredible tool for women with both endometrial and cervical cancers. So just did a bit of a summary of some of the immune therapy drugs. These are just PD-1 inhibitors. So one type of immune therapy. The Keynote 158 study used a PD-1 inhibitor called pembrolizumab just by itself. And the response rate in patients that either had MSI high, mismatch repair deficient, or tumor mutation burden high, in each case, you'd probably have high amounts of TILs. 57.1% of patients with late stage tumors responded. Another drug called durvalumab, there was a 43% response. Another drug called dostarlimab or dostarlimab had 43% response. I don't know where they come up with these names. And then avelumab had a 26.7%. So these are all PD-1 inhibitors made by different companies. Typically, we use pembrolizumab or nivolumab or atezolizumab because they work relatively the same. A lot of these other PD-1 inhibitors, they're not as good, but this just goes to show there's many companies using PD-1 inhibitors, and PD-1 inhibitors are very good for endometrial and cervical cancers. But of course, you need to do the genetic testing and the molecular testing to determine whether these drugs are going to be beneficial for you or not. If you don't have the features as defined on the previous page, then you're probably not going to respond to these drugs. So the next slide. So what if you don't have MSI high, MMR, or TMB? Then a PD-1 inhibitor by itself is not going to work for you. However, there is now a new trick that we're using, and it's where we combine it with a drug called a dirty kinase inhibitor. And so what lenvatinib is what we call a tyrosine kinase inhibitor. And basically that just means it inhibits certain genetic pathways by inhibiting with their tyrosine kinase domain. And that's what we call, the tyrosine kinase domain is just the activation domain of a gene, a certain class of genes. So lenvatinib was designed to inhibit certain genes, and purely by accident, they found that it actually inhibited a ton of different genes, and therefore it wasn't as good as what they thought by itself. So they couldn't use it to inhibit just one gene because it accidentally inhibited a lot of genes it wasn't supposed to. And so we call it a dirty kinase inhibitor. In other words, it's not as accurate as some of the other drugs that were its competitors. However, because it inactivates all of these pathways, it causes the tumors to look very different and express a bunch of antigens, and therefore it can be recognized by the immune system much better. So it's a way of turning an immune dead tumor into an immune active or immune sensitive tumor. So this study combined pembrolizumab, the PD-1 inhibitor, plus lenvatinib in women that would not normally respond to immune therapy with endometrial and cervical cancers, and it caused them to respond to endometrial cancers. So as of July 2021, the FDA has approved of this combination for any woman with endometrial or cervical cancer. So this is what you should be getting in Canada. Canada is still waffling. They don't want to pay for these drugs. That's the simple solution. But if you do have endometrial cervical cancer, this combination is likely going to be a very good solution for you. You can probably, if you push your local cancer agency and you tell them, hey, listen, this is FDA approved as of July 2021, you should be giving it to me. It's ethical for you to give it to me. We know it works. You may have to pay for one of the drugs, who knows? But really, this should be given to all Canadian patients as of now. So this trial was in heavily pretreated women. The overall response rate was 31.9% with this combination of drugs versus only 14.7% with chemotherapy. So almost doubling the response rate. The duration of responses was 14.4 months, that's the average, versus 5.7 months with chemotherapy. And the overall survival was 17.4 months in mismatch repair proficient. So if you actually had TMB high, mismatch repair deficient, or MSI high, then you would probably have a huge response to this combination. And so once again, the chemotherapy was only 12 months response or overall survival. So
Alex?
Yes.
Oh, sorry, I didn't mean to scooch ahead there. I think it's relevant here to just kind of reinforce the heavily pre-treated. So these are like fairly advanced, already tried lots. So for what we see with, studies like this and data like this is, if you're not already heavily pre-treated, if your cancer isn't supremely advanced and you try an option like this, you have an even better response.
Of course. Yeah. So once again, clinical trials are used on the sickest of patients, and then once they're shown to be effective, they are moved to the beginning treatment. So while this was proven to be effective in heavily pretreated patients, the fact that it works on those patients means it's going to be really beneficial for people who've just been recently diagnosed.
Right.
So if you've been recently diagnosed, this is a treatment to get on. It's probably going to be a huge, huge benefit for you and produce a long-term durable response, which is going to be way better than the statistics here and the data here. So good point, Michelle. Yes.
Thank you.
Yeah. So another thing too is HER2 testing. So we like to do HER2 testing on gastric cancers and endometrial. We actually had a patient about 7 or 8 years ago. We convinced our oncologist to do HER2 testing on them, and it came back as she had high HER2. So HER2 is something that is commonly found overexpressed in breast cancers. And HER2, there's many drugs for HER2 overexpression or overactivation. There's a ton of great new technologies. So if you have a HER2 positive disease, there's going to be a lot of good drugs for you, regardless of the type of cancer you have. And this is just an example of HER2 applied to endometrial and cervical cancers. A recent study showed great results by combining Herceptin, the anti-HER2 drug, to the standard care of carboplatin and paclitaxel. And interestingly enough, there's a type of cancer called uterine carcinosarcoma, which does not respond to chemotherapy. And these patients have a high amount of HER2 overexpression. So this is a great drug for them. So if you have endometrial cervical cancer, ask your doctor to get you HER2 testing. It's a simple, cheap test. It can be done in your pathology sample. Even if you have to pay a couple $100 for it, get it done. Or if not, we can get it done for you. So next slide. So we're going to go a bit into cervical and vaginal cancers. Not a lot of research on these cancers, not a lot of treatments. The doctors are usually stymied by this and don't know how to treat it after surgery. Once again, TILs are also found in cervical. Cervical cancers are usually caused by HPV. There was a new study that just showed that when you get the HPV vaccine, you get a radical reduction in cervical cancers and head and neck cancers, because they're also caused by different strains of HPV. So women that get HPV vaccines early on in life have almost no cervical cancer and minimal head and neck cancers. Men should get HPV vaccines because they can get HPV related cancers, including head and neck cancers. Throat cancers are often HPV caused. So once again, the HPV vaccine, get it. Regardless of who you are, get it when you're young, get it when you're old, just get it. You can go to a pharmacy and you can get it, and it will greatly reduce your chance of getting HPV associated cancers. However, if you do have one of these cancers, regardless of whether it's HPV or adenocarcinoma, HPV typically causes what we call squamous cell versions, but in this particular case, we're just looking at adenocarcinomas. So once again, high TILs and cervicals. And so a recent trial that used a PD-1 inhibitor, nivolumab plus a CTLA-4 inhibitor called ipilimumab. Ipi is what we call it. This study was called the Checkmate 358. The response rate was 26.3% in late stage patients. And then for the average response rate, as you can see, was 26.3%, but as many as 51.2% of the women responded to this combination. So that was the confidence interval was high. And then for cervical cancer, it was, and so 20% for vagina and vulva cancers. They didn't get quite as high a response rate, but if you look at the confidence interval, it was as high as 71.6%. So, it's important to understand that there hasn't been a lot of research in these cancers. They're fairly They're not typically treated with this combination of drugs. I suspect as we see more of these clinical trials using these drugs, you'll see much higher response rates in both vaginal and vulva as they apply them to, cancers that have high amounts of TILs and TMBs and MSI and mismatch repair and so on. Definitely, this is a treatment option that we would consider for any sort of cervical or vaginal cancer, even with a 20% response rate that can be as high as 71% or 72%. Another option is a lot of the cervical cancers have high expression of the tissue factor that is the indicator for mirvetuximab that we described recently. So once again, you need to get tumor DNA sequencing and RNA sequencing if you have either of these types of cancers. Next slide. I thought I'd throw this in. This is a rare type of cancer, choriocarcinoma. It's a fast-growing cancer that basically grows in the uterus. It's the tissues that would become the placenta. And typically, you get everything cut out and it's not a problem. Some women have a very aggressive form of this, and there's really no treatments for it if you do have an aggressive form. So this is just a case study because of it's so rare. So in this particular case, they had this aggressive form. The woman was actually a doctor, and she had this regressive treatment resistance form. She had one of the tools that they use to measure this disease is called the beta HCG, and her rate was close to 1,000, which is incredibly high. So she was given 2 doses of pembrolizumab, the PD-1 inhibitor, and immediately she responded to it, and her beta HCG levels went down to 0, and she's had a sustained durable response. So obviously, this is a treatment option for a woman with this type of cancer. So definitely lots of treatment options. And immune therapy is a huge thing in gynecological cancers. We haven't yet quite come up with the exact combination for ovarian, but all of the other gynecological cancers tend to respond to immune therapy. So definitely I would be looking into that. So next slide. So treatment monitoring. This is the 4th pillar. And one of the things we like to do once you've had tumor DNA sequencing is we like to pick a mutation, an early mutation that is indicative of your tumors. In other words, this mutation only occurs in your tumor. For example, the KRAS G12D mutation or some mutation that causes your tumor. And then what we do is we measure the amount of that mutation in your blood. So tumor cells release their mutations through exosomes. They also release them when they die, but when they release them through exosomes, it's a metastatic process. So we have a liquid biopsy. In other words, we take sample of your blood, we isolate these exosomes, and we look for this mutation that we know is only in your tumor cells. And that gives us an idea of whether you're responding to treatments very quickly. So for example, what we'll do is let's say you have this KRAS mutation. Before you start treatment and you're about to start a new treatment, we're not sure if it's going to work or not. We want to see if it's going to work or not. So what we do is we'll take a sample of your blood, and let's say your KRAS mutation's at 8% before you start treatment. Then 2 weeks later, after you start treatment, we'll take another sample of your blood. And if that mutation has gone down to 2%, then we know the treatment's working. If it stays the same or goes up, then we know that that treatment is not working and we need to find another treatment. So we've actually been able to find treatments for patients just by using these liquid biopsies and randomly trying different treatments. It's not the best way to do it, obviously, but it allows us to tell right away whether a treatment's working without having to wait 4 months to see if your tumors have grown or not. Okay, next slide. So a really important thing, and I believe we're the first to ever use this, although we're going to be seeing a lot of this soon. When you take immune therapy, because you have these TILs, these tumor infiltrating lymphocytes already in your tumor, they're just turned off. When they get turned on, they mass produce and they start copying themselves and bring in more immune cells. And so what that can do is it can make the tumor get much bigger, even though it's just full of immune cells. It's these immune cells killing the tumor from the inside out. So 30% of patients that get immune therapy get this condition, and it's referred to as pseudo progression or fake progression. And what happens is the tumors look bigger. And then also another thing that can happen is most imaging can only detect tumors that are about 0.5 centimeter or a few millimeters. If you have a tumor that's smaller, maybe 1 millimeter or 0.5 millimeter, imaging is not going to be able to detect it. But if you get immune therapy and the immune cells inside of that tumor cause it to get bigger, cause it to get 3 or 4 millimeters, then all of a sudden it will be recognized. So when we first started using immune therapy about 6 or 7 years ago, a lot of times we would see the tumors get bigger. 30% of the time we'd see the tumors get bigger, and then a bunch of new tumors would show up where there wasn't previously tumors. That was pseudo progression. And so what was interesting is the doctors would say, oh, the treatment's not working, the tumors are growing bigger, and now there's new tumors. And so they'd take the patients off the immune therapy. And then 2 or 3 years later, the patients would call up the doctor and say, hey, I'm still alive, and I don't know what's happening. The doctors would be, wow, we thought you'd be dead. So what's happening is this pseudo progression. And so pseudo progression can happen at any time when you're on immune therapy. And it's really literally impossible to tell whether you have pseudo progression or not. So one of the things that we get a lot of is we get calls from patients who are saying, I feel great, I'm on immune therapy, my doctors are saying my tumors are getting bigger. We did a PET CT and the pseudo progression is showing my tumors are bigger and there's more tumors. The doctor wants to take me off, but I think it's working. So we'll do this immune therapy, we'll do this liquid biopsy, and we'll say, oh, your KRAS mutation or your BRAF mutation or whatever mutations you have are really low. They're only 1 or 2%. Obviously, the immune therapy is working, and we'll send this information to the doctor, and the doctor will then have some reason to keep you on immune therapy. And typically, you'd get a PET CT, but a PET CT cannot tell whether you're having a response or not with immune therapy, because the immune cells will be drinking up a lot of the sugars. So as I mentioned, immune cells inside the tumor and the tumor cells have a lot of similarities. And one of them is that the immune cells, when they're active and destroying the tumor from the inside out, will drink up a lot of the PET fluid. So they will look like a hot tumor. So you'll get a really high SUV. So, PET CT is not a good way for determining whether you have a response to immune therapy. So literally the only response is to either wait it out, or the only way to determine if you're having pseudo progression is to wait it out or get one of these liquid biopsies. So next slide.
Sure.
So you want to finish up here, Michelle?
Sure, here's our summary. And there's some excellent questions in the chat waiting for you. And for those of you who came in a little bit after we started, please go ahead and you can post any questions that you'd like to have Alex answer in the chat, or you can put up your hand and we'll make sure that he gets to speak with you directly. So first of all, thanks for sticking with us. That was a lot of information, a lot of science, a lot about what's new and what's possible for a number of different types of gynecological cancers and just cancer treatment and diagnosis in general. So in summary, we now know cancer is caused by genetic mutations. There are currently hundreds of different types of targeted therapies. There are well over 600 known cancer-related mutations in our genes, tens of thousands of possible mutations that can be identified with that RNA expression testing. And it's those precision diagnostics of the tumor DNA testing and the overexpression testing specifically that can tell you which treatment is the right one for you. We talked about those 3 elements of fusion genes, mutations, and overexpression as kind of the 3 main things you want to make sure that you're getting if you're going out there on your own and you're going to try to find the right test. You want to make sure that it looks as many possible genes and that it looks for those 3 pieces. Tumor DNA testing specifically focuses on some fusion genes and mutations. RNA expression testing will tell you, as Alex mentioned, which genes are there in the highest levels in contrast to what would be considered normal, so that you can make sure that those are the mutations that are targeted in your treatment. And we talked about how targeted therapies are such an exciting advancement because they deliver the drug directly to the cell that needs it, and they only affect the part of the cell that needs it. And so people live longer and they have fewer side effects as a rule on these types of therapies. What's most important for you as a person on the front lines or an advocate is that even if your oncologist knows all about these things and really wants to be able to access them for you, without this data, they can't. Because they're not allowed by their Hippocratic oath to do any harm, and they can't guarantee until they know which mutations you have that this treatment is going to be more beneficial for you than standard care. So a lot of times you might feel like your oncologist is resisting targeted therapies or immunotherapies or things like that for you, but sometimes it's a lack of knowledge on their part, yes, but a lot of the time it's simply that they don't have the data because they're not able to provide this testing for you to prove what it is that you need. So what we have been helping people with for the last 11 years in Canada is gathering this data so that you can then circle back around to your public healthcare oncologist with this information. And now they have the ability to prescribe these things for you, many of which are accessible through public healthcare funding. And of course, there's other ways. We always have ways. So I just want you to keep that in mind. And then the liquid biopsies. So 99% accuracy. We talked about CT scans, which is a normal way of monitoring cancer treatment, as having about 60% accuracy at best, and you need numerous scans over time. They can't differentiate from that pseudoprogression. So liquid biopsies is really an excellent way for you to make sure that your treatment is working as well as it should. You can find out within about 3 weeks of starting treatment. And that's just such peace of mind for people. That's what we hear time and time again from the folks that we help with this stuff, is that, oh, it's just so relieving to have confidence that I know what's going on. I know that my treatment is working well, and that I know how to advocate for myself is so important. So just before we wrap up and go into question and answer mode, I want, you're going to get a copy of this, so you'll have this info, but I want to make sure you know how to reach me, Michelle Morand. There's my email. You're welcome to reach out with any other questions that you have once you digest this information a little bit more, or if you want to find out how to access some of these things, or at any point between now and years down the road, you just want a little bit of guidance, reach out and I will direct you to the appropriate person or place. One last piece I just want to mention is that we are just rolling out this very exciting development. This has been my baby for the last couple of years, a self-advocacy training program. After years of helping Canadian cancer patients navigate in and around the system to get better care and live longer and all that stuff, I wanted to put this together into a kind of a self-study process. So we're just about to roll out our first iteration of this self-advocacy training program, and I'm looking for beta testers. So if you're interested in getting more videos, more education on this, also forms and information about how to access these treatments and tests and things like that. That's what the course is all about. And I invite you please to shoot me an email and let me know that that's something that you're interested in. You will be receiving an email after this presentation that will also invite you to reach out if that's something that you'd like to do. And I will welcome your feedback if you have an interest in getting that leading edge information and applying it to your case right now. Okay, so now I'm going to stop sharing and we're going to go and answer these questions, Alex.
Okay, some great questions there.
Yes, exactly. So let's go back to the beginning here. There was a
Okay.
couple of questions from Lucy at the beginning about PET-CT.
Yeah.
It is standard in other countries, just not Canada if you are Canadian. So how you get one is first and foremost, always hope for the best. Ask your GP and ask your oncologist if they will prescribe one for you. You are most likely to hear that it is either not indicated for your cancer or that they're not able to get one for you. One or verbiage along those lines.
Or that it won't change anything.
Oh, that's right. Or it won't change anything.
I hear
So
that
not
a
really,
lot.
not necessary. That's kind of not indicated, but yes, those are the things that you'll hear. So don't be surprised if you hear that. It doesn't mean you shouldn't go ahead. It just means they can't, the system in which they work doesn't allow them, or maybe they're less familiar with the benefits of PET-CT. At which case, there are a number of private clinics where you can get PET-CT throughout the country, just not in Alberta or Saskatchewan. So you'd have to travel if you're living in one of those provinces. It can be covered by insurance. Sorry, Alex?
Yeah, I was just going to say, often insurance companies will cover it because they know it is a better form and it extends survival.
Yeah, and most doctors are willing to prescribe it or to write the requisition for you, that you just can't get it through public health care a lot of the time right now in Canada. The PET-CT scan is used for all types of cancers, really, except blood-based. Alex, is that true?
We use it in some of the blood-based ones, well, definitely in the lymphomas and so on. And typically it's not used a lot in brain tumors like gliomas and GBM. However, it should be, because it can definitely determine some certain beneficial things and be complementary. Mm-hmm.
So yes, it's used essentially for all different types of cancers. There are a few different types of PET-CT depending on your type of cancer. So one's, for example, that's very prostate specific. So depending on who you're thinking of, Lucy, it might be a bit of a different scan from the standard FDG that Alex was talking about, but yes, very, very good tool for most types of cancers. And Lucy, I just want to acknowledge what you were saying about your mom and your cousin. So we've got a 20-year gap between ovarian cancer for mom and then your cousin, and how dismaying, yes, to see that with all these advances in technologies and treatments, the treatment recommended to your cousin 20 years later is the exact same one recommended for your mom. And that's essentially why we're here, is because that is what's happening in standard care a lot of the time right now, even though there are so many excellent new treatments, simply because those diagnostics are not being used, so that your oncologist can't prescribe these targeted therapies for you. And so standard care remains the chemo and the radiation and surgery. Edna would like to know, what is the best treatment plan or management for stage 1 endometrial cancer?
Well, I think that is a wonderful opportunity to be applying the tools we've discussed here. Definitely, I would be leaning towards immune therapy right off the bat. However, the most important thing is getting the proper testing, getting tumor DNA sequencing and expression testing. You spend the money now on those two tests and it will benefit you for the entire course of the disease and the rest of your life. It's so important to know what drugs are going to be useful for you, what things will work for you, what won't. And the only way to determine that is by spending some money on diagnostics. It'd be the best investment you could make. Tumor DNA sequencing and RNA expression testing.
Well, for two reasons. One, because then but again, because then your doctor has the evidence they need to go off book to not just follow the standard protocols of what they're allowed to offer you when. So that's how you get that personalized treatment, is by making sure you've got those personalized diagnostics. Mary, can we get liquid biopsies in Edmonton, Alberta? Yes. We arrange the service for Canadians, no matter where they live. We just arrange a nurse to come to your home and take the blood for you, and then the sample is shipped to the sequencing lab. And you don't have to go anywhere for DNA sequencing.
No.
A simple release form gives us, or another service you might use, permission to get a hold of your tumor sample from the pathology lab that will be holding it. They typically hold these things for about 20 years. So even if you had a biopsy 10 years ago, it's probably still there. And if you just fill out a form to grant us permission, we can access it and take care of all the testing and then follow up with you once we have results, which depending on the test can be anywhere from 4 to 8 weeks as a rule. Question from Allison. Will the CA125 go up during pseudoprogression? And also, how accurate is the CA125?
It's a blood marker. It's a marker of earlier stem cell, sort of progenitor stem cells. It's not a tumor-specific marker. It's not specific to cancers. It's specific to a certain type of cell at a certain stage of its life that is common in cancers. So I wouldn't, I don't like these markers. I would say CEA is probably used a little more, but it's the same sort of thing. We like to measure with, molecular features like genes and so on. So it's not very accurate. I've seen cases where it's high and the patient had low tumor burden or benign situations, and I've seen it low when a tumor, person's had stage 4 metastatic disease. So
it is one of those tests like they have in prostate cancer, where it was a helpful tool when we didn't have anything better.
Exactly. There is a good question there. She mentioned, will the CA125 go up during pseudoprogression? I don't know about the CA125, but I do know that the CEA will be low during pseudoprogression. And that's actually what some doctors are starting to look at now. They'll look at the CEA and show, okay, it's low. You probably have pseudoprogression. So definitely there is some association between CEA and pseudoprogression.
Okay, thank you. All right, so we have, let's see here. Was there anybody who was here wanting to ask your questions directly about your case? If so, can I get you to either put your name in the chat or just say me, or put up your hand. I see that we have somebody here. EA Price. Not sure what your first name is. So we'll certainly answer your questions, but I just want to let anybody else know if you have something specific to your case, please do either post the question in the chat or just let me know that you'd like to ask it directly and we'll get you chatting with Alex for your direct live consult. And Allison, just before we go into answering specific questions for specific cases, we are worldwide, not just nationwide, and it's really easy to work with us. You simply just shoot us an email or visit our website, fill out our contact form, and let us know that you'd like to meet with us and discuss your case. You'd have an initial consultation with Alex after we gather a little bit of your medical history and he's had a chance to review some of the details of your case. You'd have your initial consultation with him. From there, he'd make some recommendations for next steps for treatment or further diagnostics. And then our team would kick into gear and make that happen for you. And we would liaise with your oncologist there, giving the information to them and being available to them, specifically Alex and his team on the research side, to answer any questions they might have about any of the treatment recommendations that we're making if they're not familiar with using those drugs. We also have oncologists that we can connect you to if you need a new one or want a new one. And we also can have those oncologists speak to your oncologist to help them to feel more comfortable about some of these innovations in treatment. Because one of the main concerns that oncologists have is, if I've never run this protocol before, and is kind of brand new to the country, they'll want to know a little bit more about how it works. And so we can help coordinate that as well. A client that I met with recently said, after working with us for a few months now, she said, you know, you guys are like a concierge for cancer. And that's what I've always called us, the cancer care concierge. So think of us as, you know, we're going to tell you where the best place to eat, the best place to see a show, the place you got to go shop, all the stuff. And we can get the cab and take you there, or you can figure it out yourself, however you want to do it. But think of us like that. Okay, Mary, we'll get your question after EA Price. And you're welcome, Allison. Thank you. Okay, so let's see here. We have a question here. I have stage 4 ovarian cancer, been on 4 different chemotherapies, some that have been mentioned in our presentation, Alex. Now the cancer is spread to her abdomen and to her lung. Oh, poor girl. She's had to have it drained 10 times. That does not sound pleasant. Not on chemo right now, but taking a hormone pill, Nolvadex. Told that she's palliative, not feeling sick. Question is, what can be done?
Yeah, without knowing the molecular features of your cancer, it's impossible. We'd be guessing if we came up with anything. But what I would suggest is that you potentially, mirvetuximab would be a good drug choice for you. There's about 5 or 6 clinical trials offering the drug for free right now. I believe in Canada, if you live in Canada, but there's a bunch of different trials all over the place. So definitely I would be looking into a clinical trial for that. However, you want to know if you have high expression of tissue factor first. Otherwise, it would be a complete waste of time. So, you know, without proper molecular analysis, I couldn't make any suggestions, and I wouldn't want to make any suggestions without actually having some scientific data.
Right.
So one thing I would suggest that you get, if you can afford it, get tumor DNA sequencing. If you are hard up for money, then I would just stick with RNA expression testing. If you can afford both tests, great. Otherwise, I would just get the expression testing, and that will tell you whether you have a high amount of FR alpha and whether mirvetuximab is going to be beneficial for you or not.
Mm-hmm. Okay. And given that you're told you're palliative, they're probably not going to be putting a lot of time and energy into coming up with treatment options for you. But we've had so many people come to us this last decade who have been told they're end stage, there's nothing more we can do. And once they get this testing, the whole world opens up in terms of treatments. And as you know, Alex mentioned earlier, we were talking about immunotherapy, but it's not just specific to immunotherapy. It's just finding the mutation that needs to be targeted for you. And there are so many targeted therapies, again, which are approved for use in Canada. And therefore covered, which is important. So while you may have to pay out of pocket for testing, it does give you so many more options for sure. So Mary would like to ask a quick question live. So let me find Mary. Where are you, Mary? Oh, here she is. Okay, I'm going to unmute you. Where are you? Oh. Sorry, Mary. I think I just did the reverse there.
You muted her.
I apologize for that.
She was unmuted.
I know. Mary, I think you have the power now to unmute yourself if you so desire.
Okay, can you hear me?
Yes,
Hi, Mary.
I can hear you. Hello.
How are you doing?
I'm okay. I actually just have a quick question for you. I'm just 3 days into using niraparib. I have a recurrent ovarian cancer.
Okay.
The first one I had was 4 years ago.
Okay.
I see that you said that it's in some cases more effective with Avastin. I was told that I'm not allowed to have Avastin. I live in Alberta because it hasn't shown signs of spreading since my last chemotherapy treatments.
Yeah.
So now if I were to authorize you to go ahead and do all this testing for me, would that be a benefit for me to perhaps access that Avastin with the niraparib, or?
Well, I would say for the average person, you want it with Avastin. Avastin's kind of an expensive drug, although it's gone down a lot now, and I believe there is a no-name brand version of it available in Canada. I think the issue is they just don't want to pay for it.
Yeah, they don't.
And that's it. So if you offer to pay for Avastin and you are pushy and you say you want it and you demand it, and then if they're not going to give it to you, you want a doctor that will. We basically, what we like to do in those situations is we'll do a one-page summary of the data. We'll present it to them. Yeah. And then we'll say, okay, now tell the patient you don't want to prescribe this, even though they're going to pay for it. And in 95 to 98% of the cases, they're not going to say that because the data is right in their face. If you don't push the data in their face, then it's easy for them to ignore it and make up stuff.
Yeah, so I need that information from you in order to
from
pursue
the trial. So, we can write you up a white paper, but really, the benefits are huge.
Yeah, because I was not told anything about the possibility of there being.
They just don't want to pay for it, and that's it.
Yeah.
And so they're keeping that, and it's not the doctors. Doctors are not allowed to actually do their own research, believe it or not.
Okay.
They're not allowed to go in there and look it up and say, oh, look at this. They have to do exactly what they're told to do by their hospital.
Okay.
And then, people think that they have a lot of control, but they don't typically. Now they can apply to the tumor group and ask for it. And also this, definitely your doctor could prescribe it. It's just that they're told not to.
Yeah, and I know my doctor is the head of the Gynecological Oncology department at the Cross Cancer.
Well,
so
then there's no excuse for not applying this data. No excuse whatsoever. It's well established.
Yeah, and I actually have already had Avastin because I went to Mexico in January. But yeah, so she won't give it to me at this point. So I'm just wondering how I can get that. Yeah.
Well, we could probably hook you up with a doctor that will prescribe it for you.
Okay. Well, I will contact you after the live chat then. Thank you so much.
Yes. Okay. Good luck.
Thanks.
Okay. Any other questions at this point about the specific anything we've shared today, or specific questions to do with treatment options? There was one question that was mailed in. Let me see if I can just quickly find that here. I think this document is opening. Pardon my delay here. Oh, actually, I think you've kind of already covered it here, Alex. It was specific to different types of chemotherapy. Yeah, looks like we've pretty much covered it. Okay. In that case, we've pretty much covered it. But let's see, did I have any notes that I wanted to come back to? No, that's everything. Anything else you were thinking, Alex, that you wanted to add or would like to say?
Yeah, I think, in conclusion of Mary's question, definitely, if you have recurrent cancer, you want to get genetic testing and molecular testing, RNA-seq. Everyone with cancer should get these tests, regardless of the type of cancer. There's no reason to not get it, and there's a multitude of potential benefits to get it when you get it.
Yeah, I get cancer care really has evolved so much, and there are so many options that are just game changing for people, but without that data.
Yeah, you're just flying blind, you're guessing.
Yeah. So there are, we talked about clinical trials. There are clinical trial services we can help you access. And that's kind of, in our experience, that's kind of a very unusual need, in fact, because once you get this information, there are so many ways to access these treatments once you can prove that you need them. And most of the time, again, oncologists are willing to prescribe this stuff once the information is presented to them that it's right for you. So there haven't been many people we've worked with this decade that needed to go the clinical trial route. But it's good to know that that's an option and it's there for access, but there are lots of steps you can take prior to that for sure in order to get access. We also do help folks set up fundraising campaigns if that's something that you might need or someone you know might benefit from. And Mary just said no clinical trials available. It would depend again on your genetics and how much testing you've had done and kind of, you know, what's beneath your cancer. There may very well be clinical trials for those genes or those mutations.
Yeah, and I think something too that doctors in Canada are not paid and do not have time to look up clinical trials for you. So that's not part of what they do. Their job is to do what they're told to do at the hospital they work at. And, you know, they don't have any way of finding out what clinical trials are available to you. There's nothing going on there. All of that information is private services. You know, that's something we do. Michelle, I know you know of a service that does that for Canadian and American patients too. But there's no real connection between the medical system and clinical trials here in Canada.
Not yet. Yeah.
So a doctor's not going to know. There's no way a doctor is going to know if there's trials for you or not. Not with 100,000 trials.
No, not confidently. We even have situations where Alex and his team will do their research and put together a report recommending a particular treatment. And the oncologist will then tell the patient, oh, that's not available in Canada. And yet it is actually, and the clinic just down the road or in the next city is using it as part of their care. It's just that this oncologist didn't know that. So it's just, we could spend hours talking about the current state of cancer care and oncologists as well, and how incredibly overworked they are, how they're not being given these tools to provide you with the best care, and how stressful that is. They suffer from the highest rates of burnout of any healthcare professional. Okay, so we want to have a lot of empathy for oncologists, and at the same time, we strongly urge you to be a squeaky wheel and advocate for yourself, because there is so much more that is possible than what you're being offered in standard care. And if you just know what it is and like how to advocate for yourself to get it, it can be a life-saving tool for sure. Okay, I think that's everything.
Yeah.
So thank you very much for joining us. A replay of this webinar will be coming to your email. The PowerPoint presentation with all the information will also come, and I'll attach a few extras. We have a document about PET-CT and a few other things that you were asking questions about, so I'll send you that information as well. And at any point today and down the road, if you have any questions, want to speak to Alex, or want to just ask questions about how to advocate for yourself, please reach out to us. We look forward to speaking with you and helping you as best we can to have the longest, healthiest life possible. Thanks for joining us. Take care.